My name is Carleigh Byrd, and I'm a student at University of Texas at Arlington, and I'm going to present to you my strategic and marketing plan for an ECMO unit at my facility. The description of the facility: Willis Knighton Medical Center is located in a low-income neighborhood in Shreveport, Louisiana. We have an emergency department, 2 medical surgical floors, a cardiac step-down unit, transplant step-down unit, an SICU, a new COVID ICU, and a CCU, as well as many other outpatient facilities like a GI lab, cardiac cath lab, and things of that nature. Surrounding states take advantage of our ECMO program that has been successfully in place for 7 years. What is ECMO? The COVID-19 pandemic has brought many new challenges to healthcare. One that has hit close to home for me is the overwhelming number of patients needing extracorporeal membrane oxygenation, otherwise known as ECMO, to assist them through the detrimental respiratory effects of this virus. Veno-venous ECMO support is used in severe respiratory distress secondary to refractory respiratory failure. Veno-arterial ECMO support is used in cardiac arrest or cardiogenic shock. Strategic plan and care delivery. Renovating the empty 3rd floor located above the current CCU and opening a 10-bed ECMO unit would allow for optimal treatment for critical patients during this global pandemic and after. Rooms would be big enough for the ECMO setup, ventilator, possibly CRRT and TPE machines, the patient, the registered nurse, the registered respiratory therapist, and other necessary monitoring devices. 12 nurses would be needed to staff the unit. That's if the unit's full with 10 beds. That would be 10 nurses for one-to-one monitoring and 2 charge nurses to help with care of those nurses since they can't leave the room. 12 nurses with an average of $35 an hour, which is the state average, would equal $10,080 for every 24 hours of nursing care. 10 ECMO-trained registered respiratory therapists would be needed to staff the unit. That's 1 for each ECMO if the unit is fully staffed or fully full of patients. That's going to be $8,400 for every 24-hour of patient care. According to Polly Dowd, our ECMO coordinator, each ECMO machine and circuit is $30,000. That would be to buy one and prime the circuit. Each ECMO run brings in approximately $100,000 of revenue. Veno-arterial runs are usually anywhere between 1 and 7 days, and veno-venous runs can last months. We've had one last 75 days before. This is our cardiac wing. I will show you here. This right here is where our surgeries, the CV surgeries are, and there's our CCU waiting room here. This is the current CCU. It's a 20-bed unit, and this is the empty 3rd floor of storage right here that we could renovate for the 10-bed unit. Strategic plan continued. In the first year, we would be renovating the 3rd floor above the CCU. We would be adding 10 airborne negative pressure rooms. We would be purchasing the ECMO machines, additional CRRT and TPE machines, ventilators, and other monitoring devices, beds, a Pyxis, and other supplies necessary for these patients. In year 2, our ECMO unit would be up and running. Veno-venous and veno-arterial patients would be accepted. The kinks would be worked out by year 3. Consistent staffing, policies, and procedures would be in place. If all beds were full, the unit would bring in approximately $1 million a month. Marketing plan. This program and unit are not intended to be marketed to the public. It is intended to be marketed to other hospitals as a facility to send critical patients who require life support in the form of ECMO. Physicians and administration at other hospitals would be the target audience of any marketing. Other than word of mouth, networking, and seminars, we would also advertise our unit in critical care journals. Once more studies have been completed within our unit, we would also publish those in the journals. This is our projected volumes for the 2nd year. This is basically for each month we added an additional ECMO, and that's how we get our revenue and our profit. As patients are cannulated, receive care, and recover within the 2nd year, estimated profit for each month of the 2nd year would be about $20,000. And as the program gets its footing, the profit will increase with each month. In summary, currently our ECMO doctor is having to turn away patients who need life-saving ECMO support. We don't have the staff, resources, or room available to care for all critical ECMO patients in our surrounding community, much less reaching out to those in the other state to help them. With the creation of a designated ECMO ICU, we would be able to accommodate and care for those from all over America that need our assistance. This would be an incredible opportunity for our hospital, as we would be the first in our area to have an ECMO ICU. Thank you so much for your time.